Good afternoon. My name is Charlie Alexander, and I direct the National Academy of Medicine's Action Collaborative on Clinician Well-Being and Resilience. Thank you very much for joining us this afternoon to discuss Clinician Well-Being at the Virginia Mason Kirkland Medical Center, a case study. I will provide a brief overview of the NAM Action Collaborative and of the Clinician Well-Being case studies before turning it over to our moderator for the afternoon, Dr. Susan Corbridge. So the Action Collaborative on Clinician Well-Being and Resilience launched in January 2017 with three key goals. The first is to raise visibility of clinician burnout, depression, moral injury, and suicide, to really make clinician well-being a national priority. Two, to improve baseline understanding of challenges to clinician well-being, so not just to look where the light is, but to fundamentally understand what the drivers of these conditions are and the consequences for clinicians, patients, and the healthcare system. And finally, to advance evidence-based, multidisciplinary solutions that will improve patient care by caring for the caregiver. Next slide, please. We've assembled a group of 39 committed sponsoring organizations. They're listed on this slide and will be available afterwards. I won't go through them, but we wouldn't be able to do our work without the generous support of these organizations. Next slide. The first 2.25 years of the collaborative's operations were dedicated to laying the groundwork and raising visibility of challenges to clinician well-being. And in this next phase of work, we are shifting to action and implementation. And so we have 6 working groups that are focused on leadership engagement. So the aim is to engage leadership to transform organizations to improve well-being. The second group aims to break the culture of silence by reducing barriers to addressing mental health and advancing new norms, practices, and policies that reduce burnout and improve well-being. The third group is focused on organizational best practices and metrics with the aim of establishing organizational standards, best practices, guidelines, and metrics that improve clinician well-being. Our fourth group explores workload and workflow, focusing on administrative tasks and the electronic health record. And they are aiming to advance new models of workflow and documentation that support clinician well-being. Post-2020 sustainability planning. Initially, when we launched in January 2017, we were going for a 2-year term. After our first year, we decided we needed to extend, and so our current funding extends through December of this year. And our sustainability planning group is helping us think about how we can continue this work as a field to advance clinician well-being. And then finally, as I'll mention a bit later, we have a consensus report that released in October 2019, and we have one group dedicated to advancing the report recommendations by furthering the systems approach to addressing well-being and to convening the many stakeholders mentioned by name in the report to begin to move to implementation for the recommendations. Next slide, please. Working groups are comprised of about 65 to 70 participants across medicine, nursing, pharmacy, and dentistry. We have several professional societies and membership organizations that participate in this work, including government agencies, technology and EHR vendors, healthcare centers and payers. And importantly, we also have individual researchers, trainees, and early career professionals, and patient and consumer perspectives. Clinician burnout affects the entire healthcare team, and so we need a robust number of stakeholders for this effort so that everyone is at the table as we develop solutions. And we really do take an interprofessional, team-based approach because we don't want a solution for doctors, for example, for physicians, to exacerbate issues for nurses. And so we really focus on the system in which clinicians operate rather than on the individual professions and disciplines. Next slide. The NAM commissioned a consensus committee to evaluate the available evidence on clinician burnout and well-being and to make recommendations for change. And so this committee met over the course of 18 months. There were about 17 of them, subject matter experts, who gathered the evidence, reviewed and deliberated on the evidence, and developed recommendations on designing systems to reduce clinician burnout and foster professional well-being. And the resulting report is screenshot here on the slide, Taking Action Against Clinician Burnout, a Systems Approach to Professional Well-Being. The report presents a bold vision for redesigning clinical systems, one that focuses on the activities that patients find important to their care and which enables and empowers clinicians to provide high-quality care. Next slide, please. On December 4th of last year, the Action Collaborative hosted a meeting to elevate the findings, conclusions, and recommendations from the consensus report and to begin to translate the report recommendations to action. Please visit our website to view the video and presentations from this important meeting. Next slide. In July 2019, the Action Collaborative launched a case study series in response to requests from stakeholders in the field. The sentiment was, yes, we agree that burnout is a problem and there are many challenges to clinician well-being, but what can we do to take action? Next slide. And so the goal for these case studies is to provide organizations with information about initiatives that support clinician well-being, to inform and inspire organizations with programs and tools that support practicing clinicians, trainees, and students, and to share lessons and challenges from organizations when developing well-being programs and policies. We know that there is a lot of excellent work in the field today, and we want to bright spot and lift up these initiatives so that others can learn from earlier successes. Next slide. For initiatives to be profiled in an NAM case study, they must address system-level drivers of burnout. They have to have been implemented for at least 6 months. They must be measured and reported on using outcomes data, and they must demonstrate success in promoting clinician well-being and reducing burnout. Next slide. The case studies involved site visits, extensive interviews with program administrators, clinicians, and leadership. We went through a document review and external peer review. The case studies represent a diversity in profession, clinical and education setting, type of intervention, and 2 case studies are available on the Clinician Well-Being Knowledge Hub. One we will discuss today, Virginia Mason, Kirkland Medical Center, and the second is at The Ohio State University. It is our pleasure to be hosting the webinar today to learn more from our colleagues at Virginia Mason Kirkland Medical Center. And I will now turn it over to our moderator for the afternoon, Dr. Susan Corbridge, who is Clinical Professor and Executive Associate Dean of the College of Nursing at the University of Illinois at Chicago. Susan.
Thanks, Shirley. It is my pleasure today to be able to introduce our speakers and to be moderating today's session. And next slide, please. I'd like to introduce our speakers from Virginia Mason, Dr. Richard Furlong, who is the Section Head and Medical Director of Virginia Mason Kirkland Medical Center, and his colleague, Rochelle Manillas, who's the Operation Manager for Virginia Mason Kirkland Medical Center, Jenny Park, who we'll hear from as a clinical pharmacist from Virginia Mason, as well as Tiffany Bierbauer, who's the medical assistant supervisor. So again, it is my pleasure to welcome you all here today, and I look forward to hearing your presentation. And we will be hearing the presentation, and then we'll be doing some questions for moderation. And then we want to also hear your questions, all that you have who are attending today. So you'll be sending in questions, and we'll walk through those at the end as well. Next.
Okay, good morning. Hi, I'm Rich Furlong. I'm the Section Head Medical Director, as Susan just mentioned. And so good afternoon to those of you on the East Coast, and good evening to our friends in the UK. So here's a list of our objectives today. We're going to present an overview of our health system and our management method, and then we'll drill down to the Kirkland Regional Medical Center that the NAM case study has highlighted. And we're going to try and describe how our local culture enabled and benefits from a specific teaming structure built around initially professional development and then workflow improvement and optimization. And then we'll describe what is a novel for us change in our back office operations that was fleshed out by one of our innovation teams. It's been a big benefit to us. And we are going to weave into this a couple of clinical scenario based case studies, and we'll do our best to tie what we're presenting to that aspect of clinician burnout that we're all concerned with. And then we'll wrap up with some focused data to share. Next slide. So Virginia Mason is a medium-sized, not-for-profit health system in Washington State with a hospital and a clinic presence both west and east of the Cascade Mountain Range. So we have about 7,000 employees and about 700 clinicians in addition to our research and teaching institutes. Next slide. And so here's a view of our 9 regional medical centers dotted around the Puget Sound area. So the Kirkland Regional Medical Center sits here in the upper east side of the Seattle metro region. Our patients have a fair amount of socioeconomic range, coming from high-end suburban tract housing to very rural trailer parks not very far north of us. We accept both Medicare and Medicaid insurances, and we do partner with other health systems in the region through a number of value-based risk contracts. Next. So here you can see the breakdown of our team at this regional medical center. Essentially, we're a primary care site with a complementary mix of some specialty services. Next slide. So we like to highlight what part of our company's strategic plan that we'll be focusing on, and today that would be people, allowing staff to work on their work, which promotes ownership and teamwork, and innovation, allowing staff, involving staff, in changes to their work leads to better buy-in and better ideas. Next slide. So this is a schematic view of the Virginia Mason Production System, or VMPS, which we adopted in 2002 as our management method. And this is borrowed heavily from the production principles of the Toyota Production System. And so while a thorough review of this is clearly out of scope here, a quick primer might be in order to understand the relationship of this to what you'll hear about. So the most basic foundational level is 5S, a virtual and physical inventory control concept of sort, simplify, standardize, sweep, and self-discipline. So which for the clinical teams translates to documentation habits and performing evidence-based exams only and interview techniques. Above 5S lies standard work. So for our teams, this relates to our early and midday huddles and visit setup and MA rooming and messaging standards. And so when these things are in place or in process, one can strive for flow, or the concept of in-flow versus batching of your work. And later we'll describe a back office rooming process that is an example of achieving flow. And then more advanced VMPS concepts are Jidoka, or automation. For the clinician, this could be the application of smart tools and alerts like health maintenance modules and other EHR optimizations that provide automated flags and signals to us. And then at the pinnacle of VMPS pyramid is level loading or production smoothing. So here, spreading the work across the team is a key strategy that we'll describe. And so someday we even hope to employ our patients as contributors to their history through smart portal forms and that sort of thing is another example of Ijonka. So next slide. So now we're going to describe the structure of one of our teams. And so the origin of this began about 10 years ago, really was about wanting to create for all of our workers and our MAs in this first example, a path for professional growth in addition to their stated job descriptions, which were manning the phones and rooming patients. And so back then this felt a little bit like an ethical obligation in a broad sense. We see this now as consistent with what came along soon after our Respect for People initiative. So the values initially that we saw were capitalizing on the talents in the team and creating a sense of personal and professional reward and esteem for those individuals. And then what happened in addition to that was that we had built this deep bench. Oh, lost our connection here. we'd built this deep bench on the team, a place to delegate responsibilities, and this became sort of like a secret weapon in implementing change as well as shoring up our operations. So everyone, can you all still hear me still?
Yes.
Yes, we can hear you.
Yeah, our connection just went, video connection went down, but audio still on, so we're good. So next slide, please. So this is a kind of a schematic of the MA teams here. So all of our MAs serve on one of these teams, or one of the innovation teams, which we'll describe. It's not mandatory, but really by choice. And so there's almost universal interest in this. And when we were looking for ideas on how to structure these teams, we turned to our production system. And as you heard, 5S translates to inventory control. So in parentheses, you see the number of MAs currently in these roles. And so we have a lot of electronic and paper forms in the exam rooms and at the flow station. So if we need a new desktop form, for example, in the exam rooms, we have a team we can rapidly deploy for that for all of our, we have 43 exam rooms. Another set of teams are rooted in standard work, which translates to training. And so new templates for portal messaging or new back office rooming process like behavioral health billing, which just came along, for example, can be rapidly deployed. So the value here is in not having all these tasks fall to an overburdened supervisor, and that alone is probably worth the effort here. But really the greater value, I think, is in the engagement you achieve in these frontline coworkers who are now owners, not renters, and highly motivated to help the clinician. So this is really a key point that we want to make here. This in turn reduces that demoralizing turnover and fosters clinician efficiency and throughput and engagement by the clinicians. Next slide. So for all of us leaders at a high level, and this is probably not just healthcare, we have work in front of us that divides into product maintenance and product development, and development or innovation is what jazzes everybody up, and we all say the same things. We want to work on our work, but it most typically takes a back seat to maintenance. And so we've been talking about these cool teams that are largely in the product maintenance realm so far, but now we want to present a hardwired structure for idea harvesting and devoted time for innovation, because our belief is without that, it won't happen. And so I'm going to hand off to Rochelle Manilis, who's going to describe the idea harvesting and innovation teams.
Thank you, Dr. Furlong. My name is Rochelle. Again, I'm the RN Ops Manager. One of the ways our clinic has improved engagement was through the development of our innovation teams. Our clinic has established two of these types. One is called the direct care team, and the second is the indirect care team. The direct care team focuses on issues that are specifically patient-facing, with the goals of improving the flow for the MAs and the providers in the back office, which ultimately creates the efficiency, eliminates waste, and improves satisfaction for the team. The indirect care team focuses on the indirect work, such as phone messages and paper workflow, et cetera, which also leads to improving efficiency and satisfaction. Everyone hired is expected to sign up to be on a team, which meets once a month during the lunch hour. And the team consists of a wide range of operators in the clinic. So for example, as you can see, the direct care team has 7 providers, our pharmacist, 2 nurses, 10 MAs, 2 leaders, 2 front desk staff, and 1 team member from specialty. Some would assume that a leader would be facilitating the meeting, but this is not the case. Anyone can be facilitating the meeting or come up with a solution. There is no power gradient while they work together to come up with ideas that everyone is willing to try. We find that change and engagement is more successful when the operators who are doing the work are the ones creating the solutions. Therefore, everyone has a voice in the decision-making process as well as the implementation plan. Next slide. These are some examples of topics that have been submitted and worked on by our team. Just last week, we actually had our latest direct care team meeting, and the hot topic was our TCM process, which is transition care management. And to save on time, I'll just mention that the issue was that waste was identified in the rooming process because an MA and a nurse is involved, and the solution was to eliminate the need for an MA to save time, reduce redundancy that was found, and improve the quality of the visit. We will then PDSA, which is plan, do, study, and act. This new process, create standard work, and report out at the next direct care team meeting. The innovation teams creates a culture of collegiality and respect, which improves well-being in the clinic. Next slide. So our innovation teams would not be possible without having a process to gather the ideas or concerns to discuss. Our process here in Kirkland is what we call idea harvesting, where we see the value of creating a safe place for our team members, no matter what position they are in, to share their concerns and ideas with management. We call our idea harvesting process, Let's Work on It. This includes everyone having an icon on their desktop that auto-populates into an email that would be sent to the leaders confidently. The email consists of 3 questions. What is the issue or problem? What departments are affected? And what ideas do you have for improvement? And every week, the leaders get together during a scheduled meeting to review every single one of the Let's Work on It submitted. This is where we assign the issue to either a team or a department. For an example, it could be a provider meeting, a nurse meeting, or one of our innovation teams discussed earlier. Next slide. We track every idea in our tracking tool, organized into quarters so that we can track the volume and keep a place for the standard work that is created. For an example, during our 4th quarter in 2019, we had a total of 14 submissions. And over the last 9 years, we've had a total of 360 submissions. Again, the Let's Work on It process allows for all voices to be heard, which includes getting back to that team member who originally submitted the Let's Work on It. Next slide. Leaders that are involved in this weekly meeting include our director, our section head, Dr. Furlong, myself as the RN Ops Manager, Tiffany, our MA Supervisor, and our front desk supervisor. We have various leads in our clinic that help with training and implementing any of the changes that are made. Our goal as leaders is to create a culture in our clinic that fosters engagement, teamwork, and respect for people, which includes speaking up, which ultimately improves the well-being of all operators. Next slide. The innovation teams and idea harvesting process demonstrates an example of our respect for people goals, which reflect our foundational behaviors. Here you see 3 out of the 10 behaviors, which includes being a team player, walking in their shoes, and grow and development. One that's not highlighted is my personal favorite, is speaking up. Speaking up creates a safe environment for patients and team members. It enhances physical and emotional safety by sharing observations and concerns, listening and taking action when needed, and use I or we when sharing feedback, and saying you may make others feel defensive. Much of what we are presenting here is recognized internally as best practice and is being taught in optimizing flow workshops, including the idea harvesting process, the creation of our innovation teams, the 5S, standard work teams, and the back office. Next, our MA Supervisor, Tiffany Beer-Brower, will be discussing the value of flow optimization.
Thanks, Rochelle. I'm going to ask you all to imagine this. Next slide. Here's a case I'll read for you. It's 7 a.m. on Monday morning. Doctor has been informed that a pod MA had just called out sick. The schedule is full with 20 patients. In addition to the full schedule, doctor is on call, and one of the other pod members is out of the office. Next slide. All of our medical assistants rotate between our family practice, internal medicine, and phone room. Having standard work allows us to move the MAs around without disruption. MAs can work anywhere with anyone. This fosters a team culture, allows the flexibility to cover sick calls, and fill staffing gaps. It also holds us accountable to adhere to our standard work. All of our staff have an opportunity to also cross-train throughout other departments in our clinic. For example, we have 3 to 4 MAs that have been trained to cover at our front desk, making it possible for them to have an all-department meeting during normal business hours. In turn, they cover our phone room. We have an all-MA meeting. We also have primary care MAs that have trained to work in our specialty departments. Cross-training allows them to learn new skills, create flexibility within our clinic, and promotes teamwork throughout all departments. Next slide. Along with performing the rooming duties of a medical assistant, we train our MAs to be flow managers. This role is tasked with both direct and indirect work. As a flow manager, they will huddle with the provider at the start of the day to discuss the schedule for that day. During the huddle, vaccine orders are proposed and visit expectations and care gaps are discussed. In the room, the MA will review the medication list, update health maintenance items, and agenda set all before the provider comes in. At the flow station, they are prioritizing indirect work and providing direction to help keep the provider in flow. Next slide. A few years ago, we created our pods with an MA and room sharing concept. The way this works is there's an equal ratio of provider to MA in each pod, but they work together as a team. The MAs are working for all providers in the pod rather than being linked one-to-one. When a patient checks in, is the next available MA who rooms them. The providers all work out of a block of rooms versus being assigned a specific room. This allows the patients to flow in and out faster when you remove the barrier of a provider only being able to use specific rooms. It also ensures we're utilizing our clinic space to the fullest capacity. Both of these processes decrease the patient wait time and length of visit. The MAs feel less pressure when they know the patient or provider is waiting because they have help from their pod. The providers don't need to wait for their assigned MA to be freed up from a room to perform a task. They can call in any MA of the pod, or any MA of the pod during the flow of the visit, because anyone can room, or any MA can step in at any time. Next slide. Communication and visual cues are crucial for the pods to work. Here are some of the tools that we've created. We have color-coded door flags. Each provider has a different color that allows for a quick visual as to how many patients each provider has roomed at any given time. Door tags with a room number and appointment time for the MA to place on the provider's monitor. This communicates which room to go into next. An action needed flag for the provider to signal that they need something performed in that room. The provider places the flag on the door and any available pod MA is able to complete the task. Next slide. So let's get back to our case. Coming in on your call day with a full schedule to find last-minute staffing change could be very disruptive. But because of the interchanging MAs that all practice standard work, making this kind of adaptation seamless, Dr. F didn't even know there had been a change within his pod for that day. Now I'm going to hand it over to Jenny Park, our clinical pharmacist, who is going to discuss how we share the work across the team. Next slide.
Thank you, Tiffany. So case 2. Blue Pod is working short-staffed due to maternity leave and vacation. Dr. K is overwhelmed with all the messages he sees in Cerner. He sees a red, urgent message from a patient regarding significant swelling in his leg after starting new blood pressure medication. Next slide. Each of our regional medical centers have at least one clinical pharmacist in primary care. All pharmacists go through credentialing and privileging like our providers. And not only are we all board certified in ambulatory care, but as of March 2019, we all have our DEA license. So we are able to practice at the top of our licensure. We practice under the Washington State Collaborative Drug Therapy Agreement. And instead of CDTA for each disease state we manage, we have one agreement for primary care and no disease states that we can manage. And we ease the provider load by helping with both direct and indirect patient care. Next slide. Following is a list of most common referrals or disease states we manage: chronic opioid therapy, hypertension, hyperlipidemia, behavioral health management, which is medication management for anxiety and depression, anemia management, medication recon and review, smoking cessation, and anticoagulation therapy. Next slide. Appointments for a visit are 40 minutes for new consults and 20 minutes for established or follow-up visits. Our appointments include, but not limited to, counseling on the disease state, prescribing and counseling on medication, ordering and reviewing pertinent labs, and of course, making sure that our patients have follow-up as needed. We are able to bill for our visits. Third-party payers do acknowledge pharmacists as providers, and we can bill for complexity or time, and with modifiers as needed. As of now, Medicaid, Medicare only reimburse for CPT 99211, which is a little over $20 reimbursement per visit. Next slide. So going back to our case, pharmacists can help with indirect patient care by addressing the specific phone message and contacting the patient. With this patient, we contacted him, reviewed his concerns on the phone, but then set up an appointment for blood pressure consult, which leads to direct patient care. In the appointment, we review his blood pressure, medication options, validate his home blood pressure monitor, and with shared decision-making, we are able to start a medication and set up a follow-up visit. As this is a new appointment, which lasts about 40 minutes, we are able to bill time for 99215. And now Dr. Furlong will review and show data on how our work has impacted our clinic. Next slide.
Okay, thank you, Jenny. So we're going to start with some data that supports what you've been hearing about, starting with Jenny's team. So next slide here. So we're going to correlate the higher rates of our referrals to the clinical pharmacist team. So we gather this data. These are our regional medical centers in primary care, and these are the number of referrals. And you see an outsized proportion of referrals to the clinical pharmacist at Kirkland, and hypertension is really one of the big purposes of that. So next slide. And so what that translates to is consistently much higher rates of meeting our metric, and this is, of course, tracked month by month across all of the RMCs, and so there we are at 89%. The other thing to notice about this is that the site with the lowest referral rates also has the lowest metrics, so there seems to be a clear-cut correlation there. Next slide. We want to look at our engagement data too. So this is a biannual questionnaire that we send to all staff and providers, and so we'll be doing that again this year. So next slide, please. So this is all of Virginia Mason for all staff minus the clinicians, and so 78.8% of all Virginia Mason staff respondents were content or engaged. Next slide. At Kirkland, 90% of all staff minus clinicians were content or engaged. Next slide. Looking at the clinicians, 73.1% of all Virginia Mason provider respondents were content or engaged. Those are relatively high numbers from a national perspective, I suppose. Next slide. At Kirkland, 92.9% of providers were content or engaged. Okay, next slide. Another thing to point to, it's a little more subjective, but is longevity. So we have a history of that. Our providers here stay for their entire career. The last 4 doctors that left our clinic retired after working for us for more than 30 years. And so corollary to that is up until about 3 years ago, when we had to start replacing those folks, I'd been here over 25 years and was still in the junior half of our physician group. So we have nurses who have worked here for over 30 years, medical assistants over 25 years, and clinical pharmacists for more than 20 years. Next slide. And so this is a little bit more of a global look at quality across our region. This is Washington Health Alliance Community Checkup, formerly known as the Puget Sound Health Alliance. And so this is conducted by our major payers across the whole state now and all the big health provider systems. This list actually goes much longer than what the screenshot you're seeing here, but it looks at 34 different quality and service metrics, and our company sits at the very top of this list now. And then we interpret this as an endorsement of the process improvements through VMPS and in sharing work across the teams that we showed you here. Next slide. So just briefly about challenges. We have the same challenges that you probably all have, which is time for meetings and protecting providers' times and the economic pressures on that, needing to make the business case to support what it takes to have these robust teams built for some of this non-clinical work. We also have to think about the cultural fit in hiring people in this change-avid environment here. And then when you create a lot of change, then you have new standard work, and so you have to keep up with that. So we have skills maps to keep up with and maintain, and trainers to make sure that they have the ability to remain accountable. Next slide. And so lastly, the collegiality that makes these high-functioning multi-operator teams, innovation teams, works really starts with the clinicians. So we very much reap what we sow here. It also takes the organization and structure and leadership to support it. There are a lot of important contributors to engagement, of course, but it might be that the most important is that everyone's work feels meaningful. And so for our support staff, what you've been hearing about, that this could mean true professional development or involvement in the operations at the ground levels, and then learning a specialty kind of expertise and gaining regard and esteem for that expertise. For the clinicians, it's a little different. It's a lot of it's about lessening the burden, skill task alignment, so that we're only doing what we can and should do and spreading the work across the team. So our mentors or senseis teach us now that we should be doing more of this Kaizen or continuous improvement on the shop floor. So that means not necessarily taking people offline for big formal events, which are also important, but integrating these kind of innovation efforts into our daily management, essentially. And so I think what I'll do is end there and see if there are questions or comments.
Great. Well, thank you so much. This is Susan Corbridge again, and so I'm so excited to hear this, and this actually has been helpful for me in my own pulmonary clinic as well, and I find it quite fascinating. I do have some questions for you all that I'd like to talk about, and while before I get into some of those questions, I did just want to remind all the listeners that if you have particular questions for our group, please enter those questions using the Q&A feature at the bottom of Zoom. And you're able to go ahead and enter those now. So I'd like to start out first, Dr. Furlong, you were talking about MA engagement, and you talked about, which I find very fascinating, but so how do you think that the staff engagement translates to provider engagement and then to reduce clinician burnout? If you could speak a little bit to that.
Sure, thank you. Well, I think at a high level, what we really believe is that engaged staff have this ownership in the task in front of the clinicians that causes them to really want to help you. And that motivation and drive to do whatever it takes to help you is critically important to us. And you know, I think in the alternate scenario where an MA is sort of punching a time clock and maybe not as interested in doing whatever it takes, a lot of the burden very insidiously falls to the providers, and that's not only time consuming but demoralizing. And so that's really what we find is that we wouldn't trade our MAs for anyone, because we know that they're in the trenches with us, doing whatever it takes to help us. And so I know that's sort of a kind of a fuzzy answer, but that's what it feels like on the floor.
Great. That's great. And then I also I find it very fascinating as well about the work that the pharmacists are doing. And I again, in our clinic, we are just so very fortunate as well to have pharmacists. So I find, Jenny, the information that you presented on the way the clinical pharmacists are practicing and having their clinic is just really unique as well. So can you talk about, you mentioned the reimbursement rate at being about $20 there. Can you describe the cost benefit? Again, we saw the outcomes there, but if you'd speak a little bit more to that and about really how moving pharmacists to work to the top of their license and how you've all done that.
Yeah, so that would be for the Medicare patients. For our third party, we get the reimbursements as the other allied healthcare professionals. For me, money-wise, yes, the reimbursement for our patient is minimal. But what happens is, and Dr. Furlong, if he could actually, he'll probably jump in here, is monetarily, it may not make a difference, but the workload or our providers, I can see these follow-up patients, maybe that aren't as complex with the lower billing codes. Our providers are able to see, because we're able to fill up, free some of their schedules, able to see new patients or more complex patients, and they could still have, the equal amount of work and getting to their metrics and their goals without having to be pushed to see extra patients during their days. Dr. Furlong, anything else you wanted to add to that?
Yeah, I think Jenny's bringing up a really important point, is that one of the demoralizers is doing work that you can do, but someone else could do too. And so we're, there's actually some literature out there about, this is really fascinating to me, about if you had a primary care doctor who was a 1.0 physician and managing a panel of 2,000 people, and all of the tasks fell to the doctor, all the direct care and indirect care, it would take 21.7 hours a day to do that work. And so spreading the work across the team is not just another pretty good idea, it's absolutely imperative. And so we continue to push that here as far as we can, safely and appropriately. It really helps to have this data in front of us that show that, yeah, when you have a clinic that refers more people for hypertension to the clinical pharmacist, you actually have better outcomes. And so by pushing that, I mean, in terms of direct care, this applies to indirect care too, having our patients with simple complaints such as neck pain or spine pain that's not MVA or LNI, shoulder, knee, hip pain, even vertigo, we're working on a process to have them be able to schedule directly under the right conditions, directly into a physical therapist schedule. And there's literature about that. A lot of it comes from the military, but there is literature to support that. For the pharmacist, having patients scheduled directly for hypertension and blood pressure, because we know it's safe and we know it's effective. Setting up our PAs and nurse practitioners to be diabetes specialists to do group visits or other care for type 2 diabetes follow-up. And so we know that some of the future for us in terms of surviving that 21.7-hour work burden is to find smart, effective, safe ways to spread this work across the teams. And so it's a survival tactic, but it's also a way to make your staff feel engaged. And this is sort of the learning lesson here, is that when you have staff out there that help you with these things, they gain a lot of regard and esteem, and they feel an ownership to the work that's in front of everybody.
Absolutely. I could not agree with you more. Thank you for that. And can you talk about, is there any movement to spread your clinic's culture and structure across your institution?
Yeah, that's a great question, Susan. So we've been sitting here in the upper right corner of that map that you saw, working away at our methods and our processes that is somewhat unique, I guess. And there's a recognition by the leadership in our department. So the department chief and our vice president recognizing why not take people in our own institution and teach them all of this. And so we've been doing what we call optimizing flow workshops, which is a 3-day, taking all of our staff are eligible for this in the department. So this is from front desk receptionists to nurses and pharmacists and doctors. And about 3 per site roll through these workshops, and they learn about VMPS, and they have a half day to come out to this site and see an expanded version of what you heard about. And so we've done now, I think we did 6 of them this year and 3 last year, and we're planning for more next year. And we've had something like 400 of our department staff roll through this. And so it's been wildly popular and effective, I think. And so we're definitely making more strides to teach our own people this. the truth is we've been teaching outside customers a lot of this for a lot of years through our VM Institute. And so that's still alive and well too as a resource for anyone out there who wants to learn more about this.
And is that information on your website?
Yes, and if you have any difficulty finding that, just feel free to reach out to me and I can help connect you.
Great. Well, now I'd like to get to some questions from our participants that are listening. So they've been sending questions in, so I'm going to be asking you a few of the questions that are coming in. The first one is, as a registered nurse who wants to make change in the workflow on the inpatient side, specifically with telemetry, where would you suggest that he or she start?
I can attempt to answer this. So we're outpatient, but for inpatient, this process, like our innovation team or our Let's Work on It process, can be fostered anywhere. So it's really allowing your team members some outlet to share any concerns or issues that are currently going on, whether it's through an email to the leaders or through like a Dropbox or something, just some protected way where they feel safe to share their concerns. And then having that opportunity for the leaders to get together in a safe, protected time to review that, and then having the team themselves that are doing it get together. So I think the important piece is to respecting the time and allowing the time for them to get together and brainstorm ideas that they have, because if they have the concerns, they probably have ideas themselves that'll be meaningful when it is implemented in the end.
Great, thanks. And the second part of that question was, do you have recommendations for breaking down hierarchical structures if they exist?
Do I answer that, Rich? That's a great question.
Well, that's a question about culture, and it's a little bit of a leadership issue. I think if you have behaviors that are disrespectful, or even in a kind of more an insidious way, condescending, or I'm really holding on to my power gradient here, then there's sort of a carrot and a stick there. I guess there is a leadership element to that, but then getting people together in a work group that gets things done, a lot of times our physicians just sort of see that, we're not the only ones with the answers here. When the NAM folks were out to visit us I think it was probably about a year ago now, they happened to be here on a day when one of our innovation teams was meeting, so it was very fortunate that way. So they got to sit in on this, and I could let them comment on it, but what I remember observing is I didn't know what the topic was going to be that day. I just sort of showed up too. And the best ideas, it was something about the flow of paper records or something, and the best ideas came from a front desk receptionist and an MA, and there were lots of doctors and nurses in the room, and no one batted an eye that those workers were the ones who were really leading the meeting and coming up with the best ideas. And so I think you just sort of have to experience that and then be able to lead by example, I guess.
Absolutely. Thank you. Here's another question about the number of patients that providers are seeing. What is the average and then the maximum number of patients that providers are seeing on a daily basis?
Well, a full-time primary care doctor in our system sees probably about 84 patients a week. Here at Kirkland, we see where our schedules are built to a standard that 1.0 FTE is 90 patients a week. And honestly, that is down from probably 10 years ago, and the reasons for that are probably obvious to everyone out there, which is the EHR has been just universally a great disappointment in terms of the time efficiency, even though it does tee up more stuff for us to think about and do. So we're delivering better care, but it takes longer. The other thing is the burden of indirect care. And so I'll probably stop there because I know there's other questions, but those are the numbers.
Okay. And then, and I agree with you about the EHR and the time piece with that. And here's another question about that, too. And how much time on average do your clinicians use to document when they go home? And or do they? And I recognize from your case study that you do put in time during the day when they can document, but have you seen with this change in workflow that providers are able to spend less time documenting and doing work after work?
Well, yes, we have some of our providers, not all, that are doing work from home. And so we have some EHR tools that allow us to look at that. And it's very concerning for us. We're not just talking about this site, really across our department. And so there's some very important things that we need to put in place to reduce that. And some of it is making sure that we're seeing what we should be seeing, and that we have the support that you're talking about, and the right time, so that we're not so pressured that we're having to leave things for later. It takes twice as long to do documentation when you batch it to the end of the day. So back to that pyramid, probably the most important thing is flow, staying in flow. And so we renamed our MAs flow managers, and the concept is sort of like the air traffic controller. If you had pilots out there that were saying, I'll decide when I'm going to land this plane, it would be chaos. And so the physicians are like that too. If you allow your flow manager to kind of help you to stay in flow, we know that we do a better job of doing our documentation right after the visit, where it takes half as long. There's a lot of new models, actually they're not even all that new, where MAs get in the room and there's kind of a shared rooming process where the MAs are doing, and in some cases nurses, doing some of the documentation while you're talking, and even order proposal and that sort of thing. And we're exploring that here too. So the answer to that is rapidly changing, actually. But it's very important to make sure that you get the indirect care out of the provider's way. And so that's a whole giant bucket of work that we're addressing right now.
That's great. So with the MAs, are there any union issues with cross-training them that you've come across? That was another question from our participants.
No, our MAs are not unionized, and neither are our nurses. Okay, great. And here is another question. Do you have a system to manage provider panel sizes? Yes, we do. So I'll try to make this quick, but I've actually been this week offline in one of those big formal events where we take people offline, and working on this a little bit so I can speak to it. So we have two different ways of measuring panels. And so one of them is looking at how many patients are assigned on the PCP field in the EHR as you're their doctor. There's another method which is inferred, and so some of you have heard of Mark Murray's four-cut method, and so we perform that too, and we look at those two numbers. There's a adjustment based on how many patients that you have that are over the age of 65, what is the proportion of female patients in your practice, based on data about utilization rate. And so we come up with an adjusted panel size. And again, it's FTE prorated too. Above 2,600, that's the threshold for closing a panel right now. And so what we do is we're creating some structure and kind of a template for adjusting or titrating the number of new patients in a scheduled template, so that between 2,350 and 2,600, you're basically matching your expected attrition rate, which is about 10%. And then below 2,350 down to about 2,000, you could double that to a higher rate. So you basically are looking at the hours of operations and adjusting new patients to be able to meet the numbers across a year that would equal your attrition rate. So that's kind of a longish answer, and I'd be happy to detail that more.
Okay, great. Thank you. Again, could one of you speak to what are some of the skills that have been acquired, or the skill set that you see that you would call people your superstars on your deep bench? So any of your providers or staff that really, with the workflow model, that what skill sets do you see in them that you just think they're your superstars?
So, it's an interesting question. This is a pretty egalitarian place, and so everybody has the same opportunities, but we do have some champ roles, and so we've really been building this out. It started here and has been rolling out across the rest of our departments. For example, for our physicians, so talk about clinicians now, we have new champ roles for chronic opiate therapy, for information technology and that sort of training, for education, for quality, for standard work. And each of those physician champions has monthly or quarterly meetings that they attend in a collaborative across the different RMCs, and they have protected time to bring their content to the provider team at the provider meetings. And they're responsible for doing some offline work. For example, the quality champ works with Rochelle and one of our CSRs to devise ways to look at our registries and pull people in and look at where our metrics sit relative to our targets. So I'd say the champs for our clinicians probably are kind of our hidden superstars.
Great. Okay. Can you give more examples of collegiality given the long tenures of many of your staff?
Well, so I think the collegiality is, I know it's kind of a subjective one when it comes to longevity. All of our providers feel very fortunate to be here, and that's why they don't leave. And I think maybe it's sort of a self-selecting thing, but what they all have in common is a belief that collegiality and respect for our staff is really what makes this place special. And then, so the three pillars that is kind of a long-standing, decades-old belief are service ethic, collegiality, and spirit of innovation. And so I think it'd be something that would be probably easier to demonstrate in practice, where you have these doctors sitting in meetings or working on work groups with other staff and watching that power gradient kind of drop down to the table level. You can never completely make it go away, but you can sure do a lot to make it feel like it's not there.
And then on top of that, I think like we talk about the Joy at Work committee, who really go above and beyond and really connect the team outside of the workflow and really value the celebrations that each and every one of us has. So I think that's important and valued among everybody here.
That's great. Thank you. And Rochelle, also when you were talking about the 10 foundational behaviors, could you speak to how those were created and who was involved in that? And then also, if you could talk about, a participant has written in, if you could provide an example of which of those that you think your clinic really excels in.
Okay. Well, the Respect for People started a few years ago by the organization. I can't speak to where it came from, but it's been phenomenal here in the organization. And they've held workshops where we all come together and run through different scenarios of how to react differently and how to treat each other. And it's amazing how you feel like this should be, very self-explanatory, but sometimes you have to break it down in steps. And I think what Kirkland does really well is, being a team player. Like, we're all equal. We all listen to each other. We listen to understand. And then we do encourage that growth and development for each and every one of our employees. We meet with them every year. We discuss. We kind of reflect on what we're doing, what happened the year previously, but we do focus on what we're going to do moving forward and how we're going to grow and develop that individual in our organization, connecting with their skill set and their gifts that they have individually. So grow and develop, and being a team player is our thing.
Great. That's great. And how did you get buy-in from the organization to compensate providers for their committee time?
So we do have a system. It's called PAGE, which is Physician Activity Group Effort. So there is sort of a mechanism by which a non-clinical work can translate to compensation. And so the committee work, especially if the work translates to CHAMP service lines that I just described, does have hardwired into it some page points, and it's not insignificant amounts of money. We try to tune it to roughly equate to what you would produce if you were seeing patients instead. It's not perfect, but it's certainly close. And so I think there has to be kind of you're bringing up a bigger point about the institutional investment or belief that this is worthwhile, and that's a challenge probably for everyone out there. We like to make sure that when we're talking about some kind of initiative or the role of our staff and building a robust structure that you just heard about, that we're not just focused on economics, although I think you could make a case for the economics, but it's really about that whole, what we call a NEMOASHI, which is quality, service, throughput, economics, and people. And so imagine a pentagon with those 5 points and those elements on the corners of the pentagon, and a score of 5 is at the corner and 0 at the center. And so if you rated your clinic operations on each of those 5 things, quality, service, throughput, economics, people, where do you stand? And if you were just focused on economics alone, our belief is that the other areas would suffer or shrink. And so we're trying to maximize the performance in all these different dimensions. And so that's where the argument or the making the case, even the business case, starts with.
Great. Well, you've really done a nice job bringing in and really tying in the quality piece and the recognition of that. The other thing I think you pointed out that, Charlie mentioned earlier about the new recommendations that came out from the National Academy in October, and really the importance of the organization of support and piece for that. So you've all done a great job with that as well, and speaking to that. So a few of the other questions, and you mentioned this quite a bit with talking about your direct and indirect teams, and you've mentioned a few things, but if there's anything else, because a participant wrote in about how the clinic handles patient calls and the messaging through EHR, and how do you deal with the high load of effort outside of the face-to-face time with the providers. You've mentioned a few of those, but are there other pieces that you could, again, comment on for this participant in particular?
So I think you're asking about how do we handle the burden of indirect care, because I have mentioned that a couple of times. And
right.
So this is really hard to talk about and listen to, I'm sure, but when we measured this maybe 4 or 5 years ago, and we did it 2 different ways. We have an electronic tool, and we have people with stopwatches. The percentage of time that the providers were spending at one of our sites working on indirect care versus direct care was 55%, so only 45% of it was direct care, and it might even be worse now. And so this is really an epidemic level problem, I'm sure, for everyone. And some of it is the result of how complex care is, and some of it is patients' expectations, and we're sort of, living in the world that we've created a little bit, and some of it is the advent of the portal. At Virginia Mason, we have a higher percentage of patients enrolled in the portal than any other health system in the country. As far as I know, that's what we hear. It's about 70%, which is really astounding because we're talking about, panels of a couple 100,000 people. The important thing about indirect care is just like we've been talking about, is skill task alignment. So sorting that work to go to the right person. And so, for example, yesterday we looked at 2 different 20-message blocks from 2 different providers on 2 different sites to see which of those messages really has to go to the doctor. And this isn't always going to be the case, but 0 out of 20 in both blocks of 20 messages did not need to go to the doctor. There was some other operator that could do it. And so when the messages come in, we have a sorting tool that helps the operator receiving this to divert it to a clinical pharmacist based on a service agreement about what Jenny and her team have agreed to answer for us, to a PA, to, in some cases, the nurses, or if there's an urgent emergent aspect of it, there's a pathway for that. And then we're working on this concept of building out teams of PAs and nurse practitioners that have a block of time to help with this. And there's actually some literature about that. Boston University, I don't know if they're on the call, but they've done some of this where they take their PAs and for a half day at a time or 2 half days per week, take them offline and just have them get into these boxes and help dissipate this. And it's really going to be critically important to get that 55% down, or we're kind of all sunk.
Absolutely. There were several questions as well from participants about the EHR and contributing to burnout, and I think that's, it's definitely a huge problem for all of us. So, but it sounds like you've got some plans in place there and really some action items that you're doing. And so you mentioned the sorting tool. Can you speak a little bit more to that?
Well, I don't know if you want to talk about it at all, but so the message.
Yeah. Sorry, if I could kind of, for a specific example, the sorting tool, if a message comes in as triage, if there was like a drug interaction question, if there was a blood pressure question, if there was side effect questions from medication, automatically, those messages I get in the pharmacy box. So that's one of the sorting tools that's specific for pharmacy.
Okay, that's great. Was that set up through the EHR, or is that something that you all implemented, went in and did?
No, it's not through the EHR, which is a pretty good question. It's a provocative question. Could the EHR help us with this? So it is something that we created in an event. We've actually had 3 events over the years just dedicated to the issue of sorting portal messages. And really, phone messages are the same. It's just a different forum for the same content, basically. And so the sorting tool was something that an MA could operate. And we had to create eventually we created a tool that's kind of alphabetized so that the operator could click on the alphabetical letter of whatever it is that is the topic, and then it would take you straight to the standards and rules and even templates. So, for example, if a patient calls in with urinary tract symptoms and it's a young woman and she's had UTIs before, there is a template for the MA to gather information and then forward it to the care team where they can make a decision about what to do. Treat the patient, have them come in for a visit, have them come in for a urinalysis. And so the Kaizen events that have been held to create these tools have fleshed out quite a bit of downstream process for the complaints that come at us. It still is a big challenge, but it has done quite a bit to offload. So the alternative is everything just gets sent straight to the physician, which is you're back to 21.7 hours again. So we can't do that.
Absolutely. Absolutely. Thank you. And then also, could you speak to, because this you mentioned a little bit about this being different, obviously, than what many providers have been trained in and staff have been trained in. So could you speak about your orientation and also how much with your orientation is that you really help providers learn about the quality processes that you do?
Well, we do have an onboarding process, and I don't know if I'm going to answer this fully, but we take about the first couple of days of a new physician's work is entirely offline, learning the EHR and learning some of our cultural processes and expectations. They learn about VMPS at a basic level. And then they have a kind of a ramp-up plan that allows them to have plenty of time. Here at this site, we have 2 new providers who started with us in November, and they've already been invited to join one of the innovation teams each. And so it's just sort of a on-the-job training a little bit here. Everyone has an opportunity to learn about Virginia Mason production system through different ways, and so some people have gone further than others. There's kind of like a bachelor's degree and a master's degree and a PhD track that you can progress through, essentially, which the last would be a fellowship. So it's sort of a lifelong learning thing. It's not really something that someone can sit down and just kind of learn in a week or something.
Okay. Thank you. And then there's another question that's come in. What is the front desk staffing ratio to provider?
So right now we have 5 team members at the front desk, and we have patients that come off our elevator, and it's like first come, first serve. So we have 5 that are, so on a typical day it's 4 to 5. And providers in a day, probably about 15.
Okay, great, thank you. And you also mentioned this a little bit, but if you could maybe speak a little bit more to it. A participant was asking about the other Virginia Mason clinics. You know, why do you think they are not engaged to the level of the staff and how you all are at Kirkland? And then what would be your thoughts on how the other clinics might improve in this area?
I don't think it happens overnight with what we learn, so we're doing all that we can to connect regularly with the primary care department as a whole group with all 9 sites and sharing our learnings. And we're still learning from other clinics as well as what their processes are. We're not saying ours is like the perfect way or the right way, but we continue to connect with them on a regular basis. We have these meetings called Standard Work Guiding Team meetings where we meet monthly, and we review and make sure that we're all spreading the work the same way, so it's all standardized. If that helps and answers the question.
Yeah, I think in those 9 optimizing flow workshops, again, there's 3 individuals from every site that comes through those, and part of their trip through the Kirkland shop floor here is that they sit down the next day and they figure out what they might want to take on or tackle as an improvement project themselves. And many of them, the first thing they say is, how can we build all this? Boy, this seems daunting. And the answer is, you can't build it all right away. It took us years. So start with one thing and then build on that, which many of them have done. For example, one of the things that has emerged after doing this quite a few times now with our other sites is that if you create an idea harvesting tool like Rochelle described, that Let's Work on It icon that sits on the desktop, then you have to be sure that you have a place for those ideas to land. And so you might want to start with one little work group of people that are really engaged to kind of do offline innovation or process improvement work. And even just starting there would be a good place to get some traction and some small wins.
And are your providers given time for that? Do they get additional time to work on the quality processes?
In some cases, we don't, for the non-formal improvement work, a lot of those meetings are happening over the lunch hour, so hopefully they have time to eat lunch anyway. If someone really has to take time and do special project work, we hope to be able to point to that and reward that through the page system, at the end of the year. Sometimes the reward is just making your life better. I mean, one of the big improvement projects that happened was when one of our providers was called to a code in our building here and showed up, and he didn't have as much help as he'd hoped for, and opened up the little kit, and the supplies that he wanted wasn't there, there weren't instructions. And so we did a whole series of meetings through one of our innovation teams. It was a direct care team, and standardized who shows up and what their role is, and built out the instructions and the materials inside these kits that we use when we respond. And so while that doctor who started all this probably isn't going to get a page point for that, his reward is that when he shows up next time, at least he won't feel so overwhelmed and unsafe.
Absolutely. Thank you. And then are you using any specific tool to measure well-being? I know you talked about your data with engagement and satisfaction, but anything particular you're using to gauge clinician well-being?
We are using the engagement surveys. That's probably the main tool that we use, and there are a lot of questions in there that relate almost directly to the Mini-Z burnout scale. So the other tool is in our EHR, we have the ability to look at what we call pajama time. And so you can actually see which providers are spending time at home after 9 p.m. getting into the EHR and doing their work. And so through our informatics team, we're helping our section heads and directors to have access to this information and go out to those individuals and ask them on a one-on-one basis, you know, what's going on, how can we help you? And there actually is some other institutions have done the same thing, University of Indiana and other institutes that have done the same kind of process of looking at this data. You really need specific provider level data on what's going on, and then one-on-one help delivered to that person. Sometimes the help is relatively simple that can make a big difference. And so I'd say the engagement surveys are too infrequent to be super helpful on that regard, but at the other end of the spectrum is this these tools that can look specifically at what's happening in this provider's life.
Great, thank you. And then what do you think your next steps will be? It sounds like things are going pretty well for you, but I know there's always, as you're very involved in process improvement. So what are your next steps?
Well, there's probably quite a few things. I think we're going to take a hard look at how we organize the those non-physician specialists who can help offload some of the demand. So, for example, when patients call in with simple complaints, I mentioned that there's probably 6 different things that could go straight to a physical therapist. And the pharmacist, we talked about direct referrals for hypertension without going through the physician. We'll still need to do a referral, but maybe not a visit. And then taking our advanced practitioners and giving them the kind of protected time to be able to really help us instead of having it kind of land within the interstices of their day, which turns out to be hard and demoralizing for them too. So I think those are the big things, is to do more to do a better job of spreading the work across the team. The other thing would be that I want to do is to explore the idea of the shared rooming, which some of our friends like Chris Sinski and others have done across the country, and see what we can do in terms of making that safe and efficient, having less documentation and clerical work landing on the physician's shoulders.
Sounds great. Thank you. Well, I think those are all of our questions. It looks like we've talked about, we had those additional information or additional questions about the EHR and contributing to burnout, which you answered as well. So if you have any additional wrap-up comments before we turn it back over to our colleagues at the National Academy of Medicine.
No, I guess I feel like maybe the most important point is that, you know, when you talk to people about what makes people engaged, some people have a sense that what makes people engaged is to give them kind of a compliment or a reward and that sort of thing. And of course, that's important to recognize people. But if you're complimenting and rewarding people for work that they deep down know is not very meaningful, eventually it feels hollow. And so my personal feeling is the most important thing for us to drive towards is making everyone's work feel meaningful. So when I talk about spreading work across the team, I don't mean making someone else do work that I don't want to do, and they don't want to do it either. I mean sorting it to someone who, for them, this is the top of their skill range, and it is rewarding for them. So that's what we really have to strive for, is having everybody work at the top of their skill level so that they go home feeling like they did something meaningful.
Great, thank you. Oh, actually, we do have a few more questions here that I did not see, so I do want to ask you these. Do you use scribes?
Well, we have experience with scribes. We've used a scribe company, and you know that's somewhat costly. It's probably $40,000 a year, and the providers have the option for that if they want to contribute 2 extra patients per day for that. And a lot of our primary care docs have opted not to do that, whereas some specialists that really crank out a lot of production and visits, like dermatologists, it's really worth it. We've used MAs in room for that shared rooming model, and so one of our sites is doing that probably 70 to 90% of their visits now. And so what we're trying to figure out is, you know, spreading that across the rest of our system would it cost us more in terms of the number of MAs that we need to hire, and it still may be worth it. So that's an example of the MA scribing in the room. And I know we're not breaking any ground here because it's been done elsewhere for years, but that's the examples we have here.
And then with your MAs, you know, you've talked about a lot with what they're contributing. Do any of them ever feel that too much work is delegated to them?
I think so. I mean, I think there's days, of course, when it's a challenging day that they feel a little overwhelmed, but I think with the team that we have and they know they can, you know, spread the work amongst all the MAs within their pod, it's really made a difference for them. Because, you know, some days they'd be with a really challenging, you know, high-producing doctor, and they would feel overwhelmed with indirect work, the piece that they were doing, and now it's spread between everybody, so I think it's definitely made a difference.
Thank you. And then if somebody could just speak briefly, too, about your Joy of Committee or Joy of Work Committee, what else did they do?
So the Joy of Work Committee meets about once a month, and they look at, you know, if February is coming up or a holiday and, like, what the team can do. And they look at anniversaries, sometimes some birthdays, some huge anniversaries, like Dr. Furlong just hit his 30 years here. So we got a cake. So we look at things like that. We really team bonding activities. So we do bowling outside. We do a picnic every year. We do a holiday party in January or this Saturday. So those are some examples.
Great, thank you. Well, thank you so much. This has just been absolutely very informative, and I wanted to now turn it back over to our colleagues at the National Academy of Medicine.
Thank you, Susan, and thank you to our VM colleagues. This was just a fantastic presentation, and you just provided us with some great guidance. So thank you very much for all the time you took to give us this guidance, give us this information, and then, of course, to all of our public participants who tuned in today to our webinar. So before I close, I would just like to remind you that all the materials from the webinar will be made available on our Clinician Well-Being Collaborative website. That will include an archive of this video as well as the presenter's slides. If you would like to stay informed about the activities of the Well-Being Collaborative, please do sign up for our listserv. You can find our listserv available at nam.edu/CW. we provide a lot of updates throughout that listserv. So thank you again for joining us. The webinar has now come to a close, and we really hope that you have a wonderful rest of your week. Thank you again.